بسم الله الرحمن. صوتي كده كويس ولا امسك؟ بسم الله الرحمن الرحيم. طبعا برحب بحضراتكم جميعا في المؤتمر ال25 لقسم علاج الأورام. وبصراحة يعني حابب أقول كلمتين. يعني الدكتور يسري رستم عمل مجهود جامد جدا ان هو يطلع بقيمة المؤتمر، ان هو يجيبه في مكتبة الاسكندرية اللي هي رمز للاسكندرية دلوقتي. دي حاجة. الحاجة التانية، انا بشكر برضو زميلي واخويا الدكتور ماهر سليمان، لان هو شال عبء كبير جدا عني بالذات، لان اللي يشتغل مع الدكتور يسري رستم عينه يطلع عينه. فانا قصدت ان انا ارمي الحمل فعلا على الدكتور ماهر، لان هي very good experience to manage the process of the meeting. احنا اوقات كنا بنقعد مع بعض في زوم لغايه الساعه 2 بالليل نظبط حاجات، وناس بتطلب حاجات في متاخر وهكذا. يعني انتوا عارفين الساعه المصريه كلها مأخره. فيعني بحييكم جميعا. هو في ايه؟ ما تيجي انت تقول المحاضرة. انا كمان اول مرة يحضر معايا طفل صغير 6 شهور، وانا اتمنى انها باذن الله تبقى طبيبة ولا صيدلانية. حتى صيدلانية برضو، اصلا بترضع صيدلة يعني. ما اوكي. بسم الله الرحمن الرحيم. لا معلش.
دكتور عباس، احنا سمينا المؤتمر ليه هونينج كانسر كير.
كل الناس بتسأل عن كلمة هونينج، والدكتور يسري هو اللي حاططها برضه. هونينج يعني شحذ، يعني لما يكون عند شحذ. مش خلاص انت حطيتها، سيبني انا افسرها. شحذ لما يكون عندك مثلا حاجة مصدية وتنظفها. فالمشكلة في في الابحاث بتاعة الاورام، كلنا بندور على حاجة مستخبية عننا. احنا عاوزين الافضل للاورام، الافضل واكتر حاجة هي السرفايفل. يعني احنا عاوزين نطول الحياة بتاعت المريض طبعا بإذن الله. لو عيان جاي وعنده ميتاستاسيس يبقى عاوزين نطول الفترة اللي هو ما يبقاش متأثر بالآثار الجانبية الناتجة من السرطان المنتشر وهكذا. فكل مرحلة لها الطريقة بتاعتها في العلاج. فهونينج معناها ان يعني ان احنا ننظف بقى، يعني ننظفها ونرجعها لاصلها. فكلمه برضو تمشي كويس، صح؟ ايه رايك في التفسير ده؟
عادي، بس انا كان قصدي حاجه ثانيه.
ما بس هي حلوه كده، مشيها كده. اول مره يوافق على حاجه يعني. ربنا يبارك فيك. كده تمام يا ريس؟ طيب. بسم الله الرحمن الرحيم تاني. أنا النهاردة هتكلم على حاجة مهمة جدا. First of all, I would like to thank Stellas for inviting me to give this talk, important talk, about to start now and treat early in metastatic hormone-sensitive prostate cancer. And especially I will stress on the enzalutamide, the Xtandi. As you all know, metastatic hormone-sensitive prostate cancer, we have 2 clinical scenarios. Whether the patient came initially with de novo disease, that means the patient who present with metastatic at initial diagnosis, or the patient initially diagnosed with localized disease, which has progressed to metastatic disease after or without definite local therapy like surgery or radiotherapy. In patients with newly diagnosed metastatic hormone-sensitive prostate cancer, the overall survival is 42 months only. Okay, so it is a heterogeneous disease. Why it is heterogeneous disease? Because different metastatic sites, the functional status, the presence of cancer-related symptoms vary in these patients with hormone-sensitive metastatic hormone-sensitive prostate cancer, and usually patients will present with symptoms which include bone pain, spinal cord compression, which is rare now, urinary symptoms, and lymphedema. Why we treat early? We treat early just to extend survival and to prevent or disrupt the patient to go to metastatic resistant prostate cancer, and to provide we delay or provide an alternative to chemotherapy. When our patient came to us and I tell him you have to have chemotherapy, he will refuse to be treated with chemotherapy. So we have an alternative treatment for metastatic hormone sensitive prostate cancer. Also, to choose our treatment, we have the indication, for example, high risk versus low risk, high volume versus low volume, and the efficacy of the drug you have, and then, and very important, the safety and the quality of life of our patients. As you all know, we have a clinical evidence supporting the treatment intensification of metastatic hormone-sensitive prostate cancer. As you see from this table, we have the docetaxel, abiraterone, enzalutamide, apalutamide, together with ADT. They all proved overall survival benefits. Also, triplet treatment with the addition of docetaxel plus abiraterone plus ADT, or docetaxel darolutamide plus ADT, proved to improve overall survival in such patients. So we have here the ANZA with two important clinical trials we will go through. As you see here, there is improvement of radiographic progression-free survival and improvement of overall survival in both trials. What are the clinical benefits of Xtandi? Enzalutamide is a potent androgen receptor inhibitor and directly inhibits the androgen receptor signaling pathway by three mechanisms. First, inhibition of the androgen binding to androgen receptor. Second, inhibition of androgen receptor from entering to the nucleus. And finally, inhibit androgen receptor for binding to the DNA. We have, as I said just before, that we have two trials. The first trial was ENZAMET trial reported in 2019, and the ARCH trial also reported in 2019. The ENZAMET trial is a phase 3 randomized trial comparing patients comparing patient with metastatic hormone sensitive disease between and comparing Xtandi or enzalutamide versus the standard of care at that time. This is the only trial that comparing the anti-androgen, not placebo, but with the standard of care non-steroidal anti-androgen. Okay. The patient was stratified according the volume of disease, whether low or high. The planned use of early docetaxel, yes or no. The anti-resorptive therapy, yes or no, and the study side and other comorbidity. And as you see here, the primary endpoint, the overall survival, and secondary endpoint include PSA progression-free survival, clinical progression-free survival, health-related quality of life, adverse event, and the cost effectiveness of the drug. This is the patient characteristics, and they are balanced between the Xtandi and non-steroidal anti-androgen. In the first interim analysis, at a median follow-up of 34 months, Xtandi plus ADT significantly extend the overall survival compared to the control group, with 33% reduction in the risk of death. Also, the new update at 68 months, which is the longest duration of follow-up in these trials. Again, the event-free survival was 67 in the ANZA group versus 57% in the cohort with non-steroidal anti-estrogen, with hazard ratio of 70%, meaning that there is significantly extend the survival by 30%. Okay, the combination of this Xtandi plus ADT extend the survival by 30%. What about subgroup analysis? As you see here, that Xtandi plus ADT were smaller versus non-steroidal anti-estrogen plus ADT, specifically in high volume disease, early use of docetaxel, and anti-resorptive treatment. Again, what about the delay of clinical progression? There was a 60% delay in clinical progression with the use of Xtandi plus ADT. Also, 61% reduction in the risk of PSA progression. The other trial is similar to the other trial testing the androgen therapy, intensification of androgen therapy, and as you see here, ENDA was compared to placebo, the other with the standard of care. Okay. Again, the stratification factor include volume of the disease, low versus high, the prior docetaxel therapy, none from 1 to 5 or 6 cycle. The first interim analysis was done on October 2018, and the final one in May 2021. Here is the patient characteristic in our trial. It is well balanced between the two groups. And the overall survival, as you see here, Xtandi plus ADT significantly reduced the risk of death by 35% versus placebo ADT. Also, there is a 61% reduction in the risk of radiographic progression or death, especially in patients treated with Xtandi plus ADT. Also, 72% reduction in the risk of initiation of new anti-neoplastic therapy, which include chemotherapy or hormonal therapy. And subgroup analysis, as you see here, that Xtandi plus ADT extend radiographic progression-free survival in comparison to placebo, regardless to the disease volume, low versus high, or prior or no prior docetaxel given to such patients. Also, this trial showed that there is 81% reduction in the risk of PSA progression. Also, the combination or intensification of Xtandi plus ADT showed a 83% objective response rate versus 63% response rate in placebo group, with 36 or 37% complete response in patients treated with Xtandi and ADT. What about the quality of life? And in ARCH trial, all patients reported a high quality of life at the baseline or during the first entry of the trial. And patient maintained a high quality of life all through the study, with no significant difference between Xtandi or the placebo group. Also, the risk of symptomatic skeletal events was reduced by 48% when we combined Xtandi to ADT. Okay, so it is Xtandi plus ADT is generally well tolerated, and consistent safety profile is there, and discontinuation less than 10% were reported in Enzamet trial by 5.6%, and in ARCH trial 7.2% only. And the most common side effects in Xtandi group include hot flashes, fatigue, arthralgia. Also, Xtandi does not require concomitant corticosteroids with its complication, as you see in these slides. And if we compare two important drugs, the Enza and APA, as you see here, regarding the overall survival, radiographic progression-free survival, PSA and the other, they are almost similar. The same are similar. What is the difference, or how can we choose the best? By the adverse event. So the adverse event is different between the both. Rash and the hypothyroidism is common with APA, while fatigue and hot flashes and convulsions are common with Enza, as you see in this table. In systemic review and network meta-analysis reported last year, or yes, it's last year, 2022, to perform a systemic review to compare the efficacy of combination approach, because we don't have a head-to-head comparison between the drug we have. Okay, so they do a meta-analysis, as you see. The meta-analysis included 7 trials in metastatic hormone-sensitive prostate cancer, 3 for docetaxel, abiraterone 2, enza, and ABA 1 for each. The primary endpoint or the outcome, overall survival, secondary overcome, progression-free survival, and the other. Regarding the overall survival in this meta-analysis, all 4 interventions demonstrated significantly improved overall survival compared to ADT. So we should not use ADT alone in such situation or such status. Okay, it's very important. And as you see in the meta-analysis, that ANZA plus ADT has the lowest hazard ratio compared to ADT alone. زي ما انتم شايفين. Regarding the overall survival, as you see here, this is for ANZA compared with ANZA. Enzalutamide is more efficacy with in comparison with APA, docetaxel, and abiraterone. Also, for low volume, ANZA demonstrated improvement of survival compared to ADT, as you see here, regarding the low volume, and has the lowest hazard ratio compared to others. In subgroup analysis for higher volume disease, all 4 interventions have superior overall response, overall survival, compared to ADT alone, as you see here from the meta-analysis. The author concluded that the combination therapy with any docetaxel, ABI, ANZA, and APA provides significant overall survival benefit when compared to ADT alone. Upfront combination approach are a new standard of care for men with metastatic hormone-sensitive prostate cancer, and ADT alone, as we said, alone will likely to be used in limited circumstances when economic factors constraint is an option. يبقى احنا ممكن نستخدم ال ADT في حالات contra indication to the intensification ان احنا نقاد دراج تاني، او انا ما عنديش النهارده راجل مش عارف ما عندوش فلوس not supported by التأمين الصحي، او ما فيش حد هيصرف له، هنديله ال ADT اللي هي الcommon practice عندنا. Okay, so the enzalutamide is easy for a patient to take. It is one dose, one daily dose, and the tablet easily swallowed, and can be taken with or without food, with limited amount of follow-up during the treatment. So, in summary, in ARCH trial, Xtandi plus ADT demonstrated a statistically significant 61% reduction in the risk of radiographic progression-free events compared to ADT placebo. Also, a positive trend in radiographic progression-free survival was observed with combination of Xtandi plus ADT across all subgroups in the study. The baseline quality of life was maintained when we use a combination of ANZA plus ADT, while safety profile with the combination in ARCH trial was consistent with that in previously reported clinical trial involving patients with castrate-resistant prostate cancer. I think this is my last slide, and thank you very much.